Wait a minute. What do I, what's that in the corner of your mouth? Looks like it might be icing cake. Are you eating cake while you're watching this video on carbohydrate health concerns? Looks like we're doing the right subject today. Looks like you need some instruction on excess carbohydrates. Anyway, we're going to be talking in part one of this session on kind of introducing diabetes and blood sugar regulation a little bit, looking at the hormones that are involved in blood sugar regulation, and then also looking at some of the clinical manifestations that would be used to diagnose a diabetic. So with that, let's looking at this slide, you can see that blood glucose becomes an issue whenever you get above 100 milligrams per deciliter or below 70 milligrams per deciliter. There can be some issues, and above that you can get hyperglycemic. Above the 7 or below the 70, usually in the 40-50 range, you can get into hypoglycemia. But neither of those really determine if you have diabetes or not. So we'll be looking at some three clinical manifestations that would truly diagnose you as a diabetic. But if you look at this chart, you can kind of see that what the regulators are supposed to do, looking at insulin and some glucagon and some of those things. So we'll be going over those as we introduce the subject. So diabetes mellitus, this is the main concern with carbohydrate health, and it's basically dealing with blood sugar regulation, and a lot of it has to do with either a lack of insulin secretion or the cells are not able to take and receive the information that the insulin is sending them, and so we will talk about insulin resistance as part of. So you look at this graphic, I'm going to just go through a series of graphics that just kind of indicate the issue with diabetes. As healthcare professionals, you are going to be seeing a lot of diabetes, and it doesn't look like there is a decrease that's going to happen. As you can see, looking especially 1997, how it's starting to increase amazingly. And going up to 2014. So this is the latest that they can. It usually takes about 5 years before they get enough data that they will change things. So anyway, I got this in 2014, and you can see the increase of diabetes is just going crazy. And so in healthcare, you're going to see a lot of diabetic patients. So you can also see, look at it, look at obesity and the diagnosis of diabetes around the country up through 2015. And so you can see down in the south areas where they have the major issue with diabetes also, or with obesity, is also regulated into diabetes. And so they kind of are associated with each other, especially the type 2 that we'll talk about later. Um, I found this kind of interesting. I really didn't know that there was a diabetes belt, but they look at down in the south and kind of southeast in that area, they tend to have more type 2 diabetes than in other parts of the country. So there is a diabetes belt, and a lot of it, again, has to do with being overweight. So that's kind of interesting, I thought. And then this one, looking at Oregon, sometimes we tend to think that Oregon is a lot healthier than other states, but diabetes seems to be increasing. This goes up to 2013, but you can see, I don't know why it fell a little bit in 2013, but there's just the same type of increase that you see around the country. So Oregon's no better or worse, I guess, than anybody. And then just an association between obesity and diabetes in Oregon. You can see obesity is rising, but so is diabetes. And so they're kind of go hand in hand. And then there is an ethnicity to it. There is a genetic basis to diabetes. And you can see that if you're of African descent or Hispanic, then you are at a higher risk for getting diabetes. So you need to be, those ethnicities need to be very careful. Uh, and we've kind of noticed this around in the Dalles Hood River area where there's increase of Hispanic populations. The diabetes it tends to go up. And so there is a genetic basis. So in these populations, need to be aware of that and be a little bit extra careful so that they don't encounter diabetes. Okay. So I do kind of want you to know this chart a little bit. As we mentioned earlier, 70 to 100 milligrams per deciliter is kind of the normal range for most individuals. And if you get above 100, you're pre-diabetic. If you get above 125, you're in the hyperglycemia range of diabetes. And then below 70, normally not until you get the 40-50 range, you get into hypoglycemic range. But if you look at this chart, what it's telling you, the renal threshold is the point at which the kidneys can no longer recover the glucose from the kidneys. So in normal cases, some of you who've had anatomy and physiology know that there's a reabsorption phase where you can filter out some glucose, but it'll be reabsorbed back into the peritubular capillaries. And you shouldn't see urine or glucose in your urine. Uh, so anyway, anytime you get over that renal threshold, that basically means you're going to have glycosuria, which is sugar in the urine. And so that is one of the manifestations we'll talk about that would help diagnose you or someone as being diabetic. Now, anything over 100, I guess you could argue is hyperglycemic because 100 is the top of the normal threshold. So you can still be hyperglycemic, but not diabetic. Just means you have high blood sugar, and then hypoglycemia obviously would be below. So normally, if you look at this chart, if you start at 100, normal would be the one that goes up just close to the renal threshold and then starts coming back down, and then basically all day long it'll go up and down as you use glucose and then replace it in the blood and that kind of thing. And then hyperglycemia, obviously you go to 100 and then it go above that renal threshold or above 125, then you'd be hyperglycemic. And it really doesn't show on this chart, but if we took the blood glucose below 60, down into the 40-50 range, then you could be hypoglycemic. We'll talk about that later. So I want to go over some of the hormones that are involved in blood sugar regulation. And so normally on an exam, I would put these kind of as a matching question. So you would match them to where they come from or to their functions. So be prepared for something like that. But the insulin, I'm sure you've heard of, it's the most common thing that's talked about with diabetes, is produced by beta cells of the pancreas that are part of the islets of Langerhans. So there's other cells, but the specific cells for insulin are the beta cells, and they will release insulin in response to high blood sugar as they get signals that they need to be produced. So their functions, there's 4 that I want you to know. Increased cell glucose absorption. Obviously, insulin's going to go to the cells and it's going to tell them to take up insulin. It's also going to prevent the liver, which is full of glycogen, and one of the responsibilities of the liver is to monitor blood glucose. If the glucose level gets too low, it will release sugar to maintain homeostasis. So if you're producing insulin, the feedback system would be, well, we've got enough sugar, sugar's coming in, so you don't have to release anymore, kind of a thing. But it will basically tell the liver, if you've got high sugar, usually the sugar is going to be absorbed by the liver and then stored as glycogen or the muscles, kind of thing. And then prevents fat breakdown. Basically, this is one of the bases of the ketogenic diet, is that if you produce insulin, then, which would be due to carbohydrates, then you would prevent fat breakdown. If you eat a low carbohydrate intake, and don't produce the insulin, because you wouldn't produce it with protein or fat, then you wouldn't prevent fat breakdown, so you could lose a lot of fat weight, which works, but it's going to put you in ketosis, which for long term isn't considered a good thing. So ketogenic diets are kind of I don't know, there's pros and cons to it, but it's not one that I don't think is recommended long term. Short term, to lose weight, probably not a problem. Long term, it can be a problem if you go into ketosis for a long time. So if you haven't had A&P, the pancreas is right behind the stomach, and the pancreas produces not only digestive enzymes, but also insulin and amylin and some of the hormones. So it's both an exocrine and endocrine gland. And you can see here where the beta cells are part of the islets of Langerhans. But there's also alpha cells, there's delta cells, and there's other things in there. So the specific cell is and then this is kind of a lot of people believe that insulin is going to grab onto glucose and it's going to carry it into the cell, which is not correct. Insulin is a hormone, and hormones tell cells what to do. So on specifically on your liver and muscle cells, but all cells would have to some degree, you are going to have insulin receptors. And so the insulin is going to fit into a receptor, and then it's going to send a signal that you need to embed some transporters, which are usually called GLUT something. In this case, you can see it's GLUT4, that you can embed these transporters into the plasma membrane. So the cell can add or take away proteins as needed. So when your blood glucose is at homeostasis, you don't need the transporters in the membrane. But when you have high sugar, then the insulin is going to basically tell the cells you need to add some GLUT transporters to get that sugar out of the blood. So the glucose will go in by facilitated diffusion, and go from an area of high concentration to an area of low concentration in the cell, and then basically be metabolized or put into storage as glycogen. So this diagram is basically the same thing, but you see that the insulin is being put into the receptor, and the receptor sends a signal basically to the nucleus, and you're going to add these transporters to the plasma membrane, and then you're going to bring glucose in, and then glucose is going to be basically made into glycogen for storage by the cell. So that would reduce the sugar in the blood, which is what you want to do. This just, I don't expect you to know all these GLUT transporters, but this is just showing you that Different cells have different GLUT transporters. We were looking at GLUT4, which deals with skeletal and cardiac muscle, but you notice that the liver has GLUT2s and different things like that. So they're just called GLUT transporters. Amylin is another hormone that works with insulin. It's also produced by the beta cells and it's co-secreted with insulin. So they're secreted at the same time, again, in response to high blood sugar. And the three things I want you to know about amylin is it suppresses glucagon secretion. And we'll talk about glucagon next, which basically goes to the liver and tells the liver to break down sugars and put them in the blood to maintain homeostasis during low sugar times. Slows gastric emptying time basically means it's going to tell the stomach not to release its contents as soon. And satiety means the feeling of fullness. So it's going to help you feel fuller. And so you don't have to eat as much. Basically saying, you know, you've got sugar coming into the blood. You really don't need to be hungry. You don't need to eat anymore. A lot of times that doesn't stop us, but it's supposed to increase satiety. So you can see here where the amylin is going to be co-secreted with the glucose, and it's going to go to the liver and basically stop the liver indirectly because it's going to stop glucagon. As you can see, the amylin and glucagon are the amylin is positive, glucagon is negative, so you're decreasing the glucagon for doing that. Glucagon, as I just mentioned, they're produced by the alpha cells of the pancreas in response to low blood glucose. So they're usually used more in fasting times, like when you're sleeping at night, then the glucagon would be released because you're using sugar and you're fasting, you're not eating. And so it's going to go to the liver basically and say, liver, you know, you've got this glycogen, we need sugar in the blood, we need to maintain homeostasis to bring it up. So would you please release some of your sugars? And so they'll do that. And so it helps maintain that fasting glucose. So this slide kind of shows the idea of how glucagon works. Glucagon is going to fit into a receptor, and then a signal is going to be sent into the liver cell, and then it's going to tell the liver cell, hey, would you please break down some glycogen? And then that glycogen is going to be broken down individual glucose units, and then the glucose will be put into the blood to increase blood sugar levels. GLP-1 is kind of a new kid on the block. It's actually produced by L cells that are part of the intestine. So as you can imagine, these are going to receive signals that you've eaten things first. So, you know, when the signal is going to go to the intestine where the food's in the intestines and everything. So you're going to get that signal that is then going to stimulate the insulin. So GLP-1 will stimulate the insulin production. So it's going to stimulate the beta cells to increase that production of insulin. And then it's also going to help suppress glucagon. It's going to slow gastric emptying time, so it's going to make you feel full. But it's kind of one of those situations where they say use it or lose it. So the stimulation by GLP-1 is going to increase beta cell mass, which basically means you can increase beta cells that would be more efficient than at producing more insulin, and you can maintain that mass. If GLP-1 sometimes is not released, the beta cell mass can go down because it's not being stimulated. And so you can lose the production of insulin that way. And then it will increase the efficiency of beta cells just by using, just like, you know, pumping your muscles, you're going to increase the efficiency of your muscles and you're going to increase their mass, kind of. In this diagram, you can see at the bottom is where you're going to produce GLP-1. They're going to be produced by the L cells, and then you see the arrow is going to go up and stimulate the beta cells to produce insulin. Um, and so that's going to help regulate and increase beta mass, cell mass, and that kind of thing. Now, epinephrine is not, a part of the normal regulating mechanism for blood glucose, but it is used for the fight or flight response. So you might, if you've had AMP, I'm sure you've gone over the fight or flight response, and this response is supposed to be very short term. It's supposed to be seconds or minutes, but not long term. But if you are very stressed, I mean, you're stressed 24/7, feel like you're backed into a corner, you can't sleep because you're so worried, then epinephrine, I mean, you could have put yourself into a state of fight or flight. Um, and the epinephrine could be produced abnormally. And even though it says that the function is to stimulate the liver glucose release, which in normal cases is good because you're going to use that glucose for energy to either run or fight. But if it's produced, with under stress and is produced 24/7, eventually it can cause hypoglycemia. So that's one of the things we'll talk about when we get to hypoglycemia. But here you can see that the normal stress signal will cause the release of epinephrine, which will then fit into a receptor, and then you can see the glycogen broke down to glucose, and then the glucose put into the blood for fight or flight. But once again, if you do too much under stress, then um, the blood sugar can go down because of that stress. You don't have to know this chart, that'd be impossible. But I wanted you just to show it to you to show you how complex diabetes can be, especially for a doctor who's trying to diagnose, what is the problem with getting, why is your blood sugar level so high? And as you can see, there's different places that things can go wrong that could be causing a blood sugar problem. So it's sometimes difficult for the physician to prescribe the specific medication on the first go around. Basically, what they have to do is just keep trying things, and if it works, it works. If it doesn't, you try something else. But you can see that there's a lot of areas that can affect the beta cells and cause a decrease of insulin. There's a lot of things that could affect the release of glucose from the liver. There's just lots of different things. So it's not an easy disease to diagnose the medication for, and so it could take a while, which is not fun for a patient because they want to get it regulated, but it may take a while just to dial it in because they sometimes don't know what it is. Um, this is one of the more common progressions. Obviously, you go at the top, the first thing they would look at is uh, to look at your diet, especially if it's type 2, and weight control and physical activity. Um, if that doesn't work, then a lot of times one of the first medications, if they feel they need a medication, is metformin. And metformin is one that prevents the liver from releasing glucose. The reason for that is, even if your blood glucose is high, but the glucose is not getting into the cells because you're not producing the transporters, then your cell is still not getting glucose, and its feedback system is to say, hey, wait a minute, the blood sugar must be low because I'm not getting any sugar. So liver, would you please release more sugar so you can even become more hyperglycemic? So the function of the metformin would be to stop your liver from releasing that glucose in response, and see if that will help, if that's a problem that it would help you with that. If that doesn't work, and then they'll go to, you see on the left, the two drug combination. So again, metformin is usually still uh, used, and then they will add something else and I know it's hard to see, but they'll use something else to see if they can get that blood sugar down. But you can see there's 5 possibilities. So if one doesn't work, they may move to another one and another one. So it can take a while to get this regulated. If that doesn't work, then you go to a 3 drug combination, and just keep going. So uh, it's not an easy one sometimes to get regulated. So patients have to be patient, I guess, and doctors just keep trying, but it can be hard if you want to get it under control and you just can't. Especially if you're a teenager, and teenagers, if they find out they have diabetes, they can be very angry and upset. They don't want to be different than their friends. They don't want to stop doing what they're doing. They want to go out and, have pizza whenever they want, that kind of thing. And then to add to the fact that the doctor can't get it regulated very quickly, because it can take up to a year to get it really dialed in. So sometimes that can be very, very frustrating, and some patients will just give up and say, I just can't do it, kind of a thing. So it can be tough. I wanted to go over now the 3 things that I want you to remember that are clinical manifestations. What I mean by that is that, once again, just because you have hyperglycemia does not mean you have diabetes. Uh, Hyperglycemia is an indication of high glucose, but diabetes is some other complications that would be a result of that high blood sugar that could occur. So hyperglycemia is one clinical aspect that would lead to possibility of being diabetic. Now, normally, if you are hyperglycemic, the physician will treat you as a diabetic because they don't want it to get worse. So even though you don't have the other 2 manifestations that we're going to talk about, you still may be prescribed insulin and be treated as a diabetic because they don't want it to get worse, and they wanted to get it dialed in before it gets worse. But the 2 terms you need to kind of get a handle on are prediabetes and diabetes. So prediabetes, uh, when I was going to school, there wasn't such a thing as prediabetes. It wasn't a diagnosis. I mean, they would say your blood sugar is high, but they wouldn't diagnose you or put it in the patient's chart that you are pre-diabetic. So, but they decided to include prediabetes as a diagnosis because they wanted to watch the trends of the glucose, because usually prediabetes is normally with type 2 diabetes, so that you maybe go to the physician and he or she says, well, your blood sugar is over 100, you're 110, so you're in the pre-diabetes range, and you normally wouldn't be prescribed insulin or anything like that. But then you go back for your next physical, say, and they say they see that it's up to 120. So they're starting to see a trend that your blood sugar is climbing. And at that point, if it's at 120, they may start prescribing medications, metformin, or whatever, sometimes, because they see it trending upwards, and they don't want it to get to the 125 range. So they will make sure that it doesn't get there. So they'll do whatever. I mean, sure, they're going to talk about diet, they're going to talk about exercise, losing weight. Um, but they may also try medications, which you may not have to take long term, but they're doing it so that you don't get up to that 125, so then it gives you time to get in control. And once you lose that weight, a lot of times you will not be diabetic, so you can control it through diet and stuff like that. So pre-diabetes, you can see the clinical uh, figures for that. Anytime you get between 100 and 125, then you are going to be considered a pre-diabetic if it's fasting. So that would be when you don't eat for 12 to 14 hours and then you get a blood test. But glucose tolerance, and I'll show you a picture of that, would be where you take this kind of a sickening sweet liquid, and then they monitor your blood sugars and see if they go up and if they stay up. If they go up and go down, then that's pretty normal. But if they go up and stay up in a high range, and then you'd be diagnosed pre-diabetic. Diabetes would be over 125 if it's fasting, and then 200. Or they also are now doing, and you may or may not heard of glycolated hemoglobin, usually referred to as A1C test when it's over 7. Um, but there can be patients that come in that are not diagnosed, and they can have sugar levels upwards of 600 or so, or more. And so it's really, really high, and then they get feeling of diabetes or feeling goofy, and they go into the ER or see the doctor, and they get a sugar level, and it's upwards of 600. So that's not abnormal to see those in the emergency room, kind of a thing. So those are numbers I want you to know, so you might get a handle on those. This is a picture of a glucose tolerance test. So they'll give a kid or adult a kind of a sickening sugar thing, and then they will just monitor their sugar level, uh, and then they will see if the sugar stays up and it's in the diabetic range. So you're hyperglycemic. Uh, Again, if you look at this chart, you're over 240. Usually you're over the renal threshold. So you would have glycosuria, which is another manifestation. So you would be in the diabetic range that way. So that's one test. Um, some of you know that if you've had A&P, you know that red blood cells stick around your bloodstream about 120 days. Uh, and so this is red blood cells are used to as another indicator of blood glucose levels when they do something called an A1C test. An A1C is basically how much sugar is attached to your hemoglobin. So as your red blood cells go around your blood system, uh, depending on how high your blood sugar level is, more glucose will bind to the hemoglobin. And so that's referred to as the A1C. And they do a test on that. But so what the test would indicate basically is what your average blood glucose level has been over a 3-month period. And so red blood cells live 120 days, but they, it takes them a while to get oriented. So the assumption would be we can be pretty comfortable that we can tell what the levels were over a 3-month period. Um, so here's another picture of that. You can see a low A1C would have a few sugars on it, but a high A1C would have a lot of glucoses attached to the hemoglobin. And so here's a normal chart. You can see, um, if you're over 7, what the good means is that if you're diabetic, um, they're pretty comfortable if you can keep your A1C in that range. But if you've not been diagnosed as a diabetic and you're over 7, then that would be an indicator that you're hyperglycemic for that. And most individuals should be within the 5 or 6 range in that category. But it's hard to get, as a diabetic, it's kind of difficult to get it down into that real low range. So again, they're happy if you can get it into the 7 range in that category. So this is a more uh, a test that's used more often, and physicians, I think, are more comfortable with A1C tests to see how their patients are doing, as opposed to the finger sticks I think they still do finger sticks, but because they need to know how your blood sugar is before you eat, after you eat, how fast it's raising with what you eat, that kind of thing. So they do a pre-prandial and a post-prandial test. And so finger sticks are still important, but I think overall, to look at your average, then they need that A1C test. So the second manifestation would be the ketoacidosis, because just like the ketogenic diet, if you are not getting sugar into your cells, then the response of the body is to start breaking down fats. And they're kind of inefficiently broken down, and they get broken down into ketones. And those ketones would then increase in your blood, so then they can test for those ketones. And if you have a high level of ketones, then you would have diabetic ketoacidosis, which is another indicator that of diabetes for that. And you can see here, this chart just shows you that if you remember from, if you have any chemistry, or maybe if you went over it in A&P, you know that fatty acids are broken down into acetyl-CoA just before they go into the Krebs cycle. But in this case, when you produce ketone bodies, those acetyl-CoAs are going to make acetic acid and then become acetone, become basically ketones. And then they would increase in the blood. And your cells can use ketones as an energy source. It's a little bit less efficient. It can make you more tired um, and a little bit lethargic, but they can use those, and you definitely would break down fat. This is just a chart that kind of shows that, the liver is going to go through a ketogenesis. If you see down in here where it says ketogenesis, and will increase ketone and glucose in the blood. So that's a manifestation that your cells are not taking up that glucose, and it's being released. So if you have a high glucose and high ketones, then basically the liver is releasing those. The third manifestation is glycosuria, and glucose in the urine. And this is based on the idea of osmosis. So hopefully you've had some biology on material transport, and you talked about the movement of water by osmosis, where water will move from an area of high concentration to an area of low concentration, or basically move to an area that's hypertonic. So if you have a lot of sugar in your blood, the blood is definitely hypertonic. So you're going to have water moving from the interstitial fluid and tissues moving into the blood to try to dilute it. And so you can imagine, if you're increasing the water in the blood, then you are going to increase urine output. So you would have polyuria on that. And then polydipsia basically means you'd be very thirsty, because if you're taking fluid from the tissues, the response, the feedback is, you need to tell this person to drink some more, because, we don't have enough water in our tissues, kind of a thing. Um, so the, increased urination, increased thirst is an indicator that maybe somebody should go see the physician to see if something's going on with their blood sugar. And then polyphagia means you're hungry, because you can imagine, again, if cells aren't getting glucose, they're saying, well, this person's not eating enough for us to do anything, so we need to have them eat some more. So the feedback is please eat something. But the person may still lose weight because they're not getting any glucose into the cells, and so they're not able to utilize that energy that could come from them. Okay, one of the issues though with the being diabetic is increased possibilities of cardiovascular disease. You can see they're 400 times higher risk for heart disease because you're kind of messing with the chemistry of your body, and so there's some issues there. Nephropathy basically is your kidneys, so there's some issues with kidney function, and if you ever have a rotation in the dialysis unit, you'll find that a high percentage of those patients are diabetic. And for some reason, their nephrons have been affected. Retinopathy can give you macular degeneration. You can start blowing out some of your vessels in the retina, and that can decrease some vision, have some vision problems with that. As you can imagine, the infections will go up because you have sweet blood, and the bacteria love it. So most diabetics have to be very careful with when they get cuts, especially in areas of their feet and where they may not know they got cut, that kind of thing, because you can also have decreased sensitivity. And you can get numbness in your hands and feet, and so you may not know you stepped on something sharp, you may not know you cut yourself. So it's one of those things where they teach patients, or should teach patients, how to inspect their feet, two or more times per day to make sure there's no infections, no cuts, because you don't get a lot of circulation in your feet in a lot of cases. And so the bacteria can really munch on those and cause some infections, and then you can see the idea of stroke. So there is increased issues if you don't keep your diabetes in control. If you keep it in control, you reduce those risks. So nephropathy, you can see diabetes can lead to chronic kidney disease, and you can see in the figure that diabetes is 43% of the causes for kidney failure. So diabetes is pretty important. Um, and this is, I found this in online, and basically you can see, I don't know if in A&P we're at Columbia Gorge, if they teach you about podocytes, but podocytes deal with the filtration. And so the podocytes with diabetes seem to lack insulin receptors. And so again, they basically, insulin alters the actin cytoskeleton, so they can change and reduce filtration based on the podocyte. And so here's a picture, and you can see I highlighted where the podocytes are. They're in the glomerulus, and they're part of the filtration mechanism. So those can be affected, and so you reduce your kidney function. So that's why you might have to go on dialysis or something like that. And then macular edema, you can see basically where you can get some aneurysms because you've got that high sugar in there, and you're absorbing the water, and it's kind of expanding the blood vessels, so you can start getting some edema there. So anyway, that's our part one. And part two, we'll look at the different classifications of diabetes, and we'll get into hypoglycemia.